Good afternoon, everyone. My name is Grace Suva, and I am one of the managers on the implementation science team here at RNAO. And I would like to welcome you to today's webinar. I will be the co-moderator for today's webinar alongside my colleague Arlene, and I'd like to pass it to her to introduce herself.
Thank you very much, Grace. Hello, everyone. My name is Arlene Masaba, and I am also a manager with the implementation science team here in RNAO. It is my pleasure to help moderate today's webinar. I'd also like to introduce to you Andrea Stubbs, who is our project lead for the Best Practice Champions program. She will be online to help anyone who has any technical questions in relation to today's webinar. Our monthly information sharing webinars are a means of supporting RNAO's best practice champions and their work in guideline implementation. Our speakers are those who are actively involved in BPG implementation.
Thank you, Arlene. So today we have the pleasure of having a presentation on the assessment and management of foot ulcers for people with diabetes best practice guideline, a focus on total contact casting. And as we move to the next slide, we just want to give our webinar participants a few housekeeping items. First, we really want the webinar to be interactive and engaging. And so there will be about 10-15 minutes at the end of the presentation for questions and answers. And so we do encourage you to type them in the chat box, either your questions or comments during the presentation, and we'll collate them and then we'll field them during the last 10 to 15 minutes. Please send your questions or comments to all panelists and attendees, just so that everyone sees your questions and your comments. We will also be recording this presentation so that it can be archived for future viewing on the RNAO website. So please note that if you participate in the chat box, there is the potential that your comments and questions will be read out loud by the speaker or myself or Arlene. And so your participation is your implied consent to be recorded and posted on the RNAO website. So it is my pleasure, if Arlene, you don't mind moving to the next couple slides, to introduce you to your presenters for today. We have Agnes Kimmick, and she started working for Spectrum Healthcare as a community nurse in 2013. She then transferred to the Peel Ambulatory Clinic in 2015. Agnes is one of the preceptors for their new hires and is a dedicated BPSO champion. She is an advocate for patients and peers alike. She is genuinely interested in helping others and provides excellent patient care in a consistently positive and skillful manner. Susan Felix has been with Spectrum Healthcare for 23 years. She has had several roles within the organization, starting with primary visiting nurse, program manager, manager of clinical practice, and currently the director of clinical practice and informatics. Susan is responsible for overseeing all of the registered team's practices within the organization, that they have the knowledge and expertise in providing safe and ethical nursing care. And finally, but definitely not least, we have Holly Murray, and she graduated from Queen's University with a BSCN in 1996. She graduated from the Albany Medical Center's Ostomy and Continence Nursing Education Program in 2000. She has maintained her wound, ostomy, and continence certification with the Canadian Nurses Association for more than 10 years. She joined Spectrum Healthcare in 1997 and enjoys her current clinical practice focused on wound care and helping to improve the lives of those dealing with diabetic foot ulcers. So you may have heard me talk about BPSO. Wanted to let you know that if it's ever mentioned, it stands for Best Practice Spotlight Organization. And BPSOs are healthcare as well as economic organizations who are selected by RNAO, and this is through a request for proposals process, to implement as well as evaluate multiple best practice guidelines. So it really is a dynamic partnership that focuses on making a positive impact on patient care through evidence-based practice. Now that I've presented you to all of the presenters for today, I'm going to pass it on to the Spectrum team to start. Thank you.
Hi, good afternoon. This is Holly speaking. I'm very happy to have you all join us today as we help share some information on our total contact casting program here at Spectrum Healthcare. So next slide, please. So some of our objectives today include gaining a better understanding of the current offloading devices. Particularly, we're going to be talking about our total contact casting initiative. We're going to identify the benefits of total contact casting for patients, explain indications and contraindications for use of total contact casting, and help to provide some identifiers for the ideal patient with some examples of our TCC patients towards the end of our presentation. Now I'd like to hand it over to Agnes to share some of the information with you.
Next slide, please. Facts of total contact. Sorry, the next one. Facts of total contact casting. Established in the 1960s as a treatment for plantar diabetic foot ulcers, individuals suffering from a DFU are at the increased risk for premature death, MI, and fatal stroke. Diabetes causes 56% to 83% of lower extremity amputations annually. In Ontario, 74,000 is spent per limb amputation, and approximately 2,000 lower limb amputations occur each year. The International Working Group on the Diabetic Foot states that multiple interventions are required to heal a DFU effectively. The wound management, infection management, revascularization, pressure offloading. All these points are so important to bring the closure to DFUs. If you focus on one, you will not achieve a goal. Food for thought. The 5-year mortality rate of the person with a neuropathic foot ulcer is 45%. If an ulcer is not 53% smaller after 4 weeks of conventional treatment, there is only a 9% chance that will go on to heal in the next 12 weeks. What is offloading? Removal of focal pressure from a specific foot site area and redistribute it over the larger foot surface. Key interventions used throughout all phases of neuropathic diabetic foot and wound management. The goals: maintain soft tissue viability, redistribute pressure from bony areas, promote wound healing by protecting against pressure shear. And then you see the darker shoe, which is an example of the offloading device that could be used for plantar ulcers under the toes and front of the foot. Next slide. Preventions versus treatment. Offloading devices used for prevention provide even pressure distribution, decreasing ulcer formation. Offloading devices used for treatment completely eliminates shear and pressure to the affected area to optimize healing. This is found in TCC treatment. Purpose of total contact casting: reduces the mechanical forces, inflammation, reduces edema, redistribute the plantar pressure, limits bone and joint destruction, consolidate the progression of deformity, maintains a plantigrade foot. Why total contact casting? The most effective offloading method considered the gold standard. Healing rates as high as 95% at 12 weeks. In our experience, people are close by 8 weeks. Reduces limb amputations, decreases infection rates, cost effective, increases patient adherence, ultimately saves lives. And this photo here was used to one of our patients, which was just after the cast was done. Then you see in the corner. Next slide, please. The indication for total contact casting: plantar DFU, Charcot foot, no active infection, ABPI of equal, greater 0.5 to 1.40, or toe breaker pressure index above 0.5, no allergy to casting material. This is a photo here, which was done in our clinic just before casting. the contraindication, active or acute deep tissue infection, osteomyelitis, exposed tendons, joints, and or bones, arterial insufficiency, gangrene, critical limb ischemia, ulcer depth greater than ulcer width. Here we have examples of the total contact cast eligibility. And you see on the pictures above, there are the ideal pictures taken for diabetic foot ulcer located on the plantar, midfoot, or heel. In the middle, we see the pictures of Charcot neuropathy, acute or subacute. And as well, we have a specialized TCC walking boot to accommodate Charcot foot shape. And as well, at the bottom, you see the pictures, some examples of post-operative care, including but not limited to Charcot reconstruction, delayed primary closure, post-tendon Achilles lengthening. Now I will pass you to Susan. She will just introduce you to the screening we do at our clinic before starting application of total contact casting, the whole process.
Thank you, Agnes. So yes, at Spectrum, we use electronic medical records through the Procura operating system. And so to help assist our staff with identifying patients who are eligible for the TCC treatment, we have incorporated into our documentation tool the key questions that help identify patients who will be eligible for the treatment. And this is built and guided through our diabetic foot ulcer pathway within the system. So the tools are there to prompt within the record the nurses to complete the correct assessments, ensure the ABPI is completed, and help work towards getting the best outcomes for our patients.
Next slide, please. So some of the reasons why we've had to stop TCCs in our clinic. First point is safety issues. We've had some people where we've done a gait assessment and they've seemed appropriate for TCC, but once we get them into the total contact cast, we find they're not able to accommodate with their gait. So mobility is an issue. Initially, we do recommend that people, if they have a cane or a walker around, once they're initiated into the TCC, that they may want to use that until they get comfortable with the cast system and the walking boot. Another safety issue is non-adherence to the schedule. We did have to stop 2 TCCs because the patients were not showing up for their appointments. So that was a major safety issue, having a patient out there with a wound and a cast and not coming in to have it removed regularly. Lack of family supports. If the patient has the cast on the right foot, they are not able to drive. So if they can't take public transportation or they don't have family supports to bring them to the clinic for their appointments, that can be something that prevents us from getting someone into their total contact cast. And mental health is a big aspect as well. Anxiety and claustrophobia. These people are in a cast that they cannot remove. And for some people, that can be too much for them to cope with. So that is something that we do have to keep in mind. And lastly, a change in diagnosis. Sometimes we find with this diabetic population that new deep tissue infections develop. So if that's the case, we have to temporarily stop the total contact cast until we can resolve that deep tissue infection, and then we can return to the total contact cast. Undiagnosed or misdiagnosis of osteomyelitis is another reason why we've had to stop TCC. Next slide, please. So I'm going to go over some of our success stories, but before I do, just a tiny bit of background. The total contact cast system that we use is the TCC Easy system. It's made by Integra Life Sciences. And our clinic provides all of the TCC application, and all costs are covered by the Mississauga Halton Lynn. This is a program that was established by them And we are very thankful for it that our patients have access to this and that all costs are covered. When we begin TCC, the recommendation is that the first cast is changed after 48 to 72 hours. And then after that, we do change it once or twice a week, depending on the amount of drainage and the wound presentation. We do tend to use an antimicrobial with all of these patients because we do not have eyes on that wound for a week. So to help ensure that we're maintaining safety at the wound site, we do tend to use an antimicrobial. Before we begin, we do need a medical order for total contact casting from a physician. We do also need a duplex arterial Doppler study and hopefully some toe pressures if we can get that, and they need to be completed within the last 12 months. And then we have a discussion with the patient and make sure that they're in agreement with the whole casting process. So now I'm going to share with you 3 examples from the patients that we have had that have successfully completed our TCC program. So if you could advance the slide, please. Thank you. So this first patient here had a diabetic foot ulcer for greater than 6 months when he was referred to our clinic. Upon assessment, the nurses identified that he would be an appropriate candidate for total contact casting. So as you can see from the dates here, we began casting on April 24th. And within 3 weeks, this ulcer that had been present for greater than 6 months was closed with the total contact cast. So once they are, the site is closed, we do cast them for 2 additional weeks, which allows for improved tensile strength and maturity at the wound site before they're discharged. And all of our patients are discharged into a Darco offloading wound care shoe that is also provided by the Mississauga Halton Lynn. And they all have a referral to a chiropodist that is strongly encouraged so that they can continue to have routine callus debridement and look at other orthotics or shoes or custom shoes so that they have consistent offloading ongoing. Advance the slide, please. Thank you. So our second patient here had this diabetic foot ulcer for greater than 2 years. He had gone through multiple air casts and custom orthotics, but when we started really investigating, we found that he wasn't wearing his offloading consistently. So because he was inconsistent in using his offloading, he wasn't getting healing at his ulcer site. So this gentleman, despite some issues with anxiety and claustrophobia, decided he wanted to give total contact casting a try. So we did begin casting him, as you can see here, on May the 8th. That's the first picture. And within 3 weeks, we had really good progress towards closure. However, unfortunately, this gentleman did have some anxiety and he was feeling very claustrophobic and wasn't coping well. So he did go to one of our local hospitals in the middle of the night to have his TCC removed. It was sad that that happened, but the good news was that he had learned through the use of the TCC the importance of consistent offloading. So he was agreeable at that point to go back into an air cast, and he understood that consistency was key here into helping his site to heal. So although the TCC stopped, it was really good as an educational tool to show him that getting the pressure off is what was going to heal his wound. So he did go on to closure. And I have actually recently run into this gentleman out in the community, and he remains closed with custom shoes with orthotics, which he says he wears on his feet all the time. So it was a really good teaching moment here. So if you could advance the slide, please. Thank you. So our final wound here, or DFU, this gentleman also had a DFU for greater than 2 years. He had been off and on our service through the LIN over that 2-year period and refused to consider TCC. He didn't understand the importance of offloading. He kept asking us for a cream or a salve or an antibiotic and believed that that would heal this site. We finally convinced him to give the total contact cast a try for a couple of weeks and said, you know, if we don't see any improvement, we'll stop it, full well knowing that we were going to get an improvement. So we did get this gentleman into the cast, and as you can see, within a month, he was closed. So he'd been dealing with this ulcer for greater than 2 years. We get him in the TCC and he's closed. So again, great education here in terms of offloading to prove to the patients that that is what is going to work. We have kept this patient healed, and we have not had him back to us. So just 3 examples out of all of the people that we have had. And hopefully that gives you some food for thought on why TCC is a valuable tool in the toolbox for healing of diabetic foot ulcers. So that concludes our presentation. We're more than happy to answer any questions that anyone may have. Thank you.
Thank you so much, Spectrum team, for that excellent presentation. And just to let everyone know, registrants will also receive a PDF copy of this presentation, as well as the contact information in case you have any questions afterwards. So please feel free to type any questions that you may have in the Q&A box. And I just want to thank Spectrum Health for being able to showcase for us through impactful pictures the impact of best practices when it comes to offloading, and best practices when it comes to managing diabetic foot ulcers in terms of the education and the processes that you put in place in order to get these positive outcomes and prevent the catastrophic outcomes that you have identified earlier in your presentation. So we have here Angela saying great presentation, and definitely this is a snapshot of a bigger picture of the diabetic foot management as well as total contact casting. Do we have any questions from anyone? And Arlene, if you see any questions as well, please feel free to jump in.
Will do, Grace. I just wanted to say that I find the topic you have presented fascinating and empowering, because it not only shows your active implementation, but your client or your patient involvement as well. So there is this question, what do you think are the factors that have contributed to your successful implementation?
I think one of the key success factors was the collaboration between the LIN and the agencies that are providing the actual home care resources. We've been very well supported by our LIN in this initiative, with them providing us access to offloading devices, which we can then take to our patients and share with them. And we also find that we get quite a lot of buy-in once we get a patient into either an offloading Darco shoe or the TCC, because they start to see the results and they see those results quickly.
Thanks very much. There are some comments here from Agnes, I think, who's saying thank you very much for sharing a very informative topic. And Melody is saying awesome results for DFU patients. There is a question here from Jenny. With the onset of COVID, is scheduling a patient for vascular testing a challenge?
We're not finding that it has been a challenge. It does require a physician-led referral, but we're not finding that the wait times are any longer to have a duplex arterial Doppler study done at a vascular lab. In fact, in some cases, we're finding that we're getting the results quicker at the moment.
Thanks, Jenny, for that question. Here's another question from Melody. What is the cost of these devices, and does the patient have to buy them?
Thank you. That's a very good question. The Mississauga Halton LIN covers all the costs associated with this. It just requires a referral to the LIN and then the medical order from a physician, the duplex arterial Doppler that's been completed within the last year. And then they're scheduled into our clinic, and we provide all of the casting material and the Darco wound care healing shoes. All those costs are covered by the Mississauga Halton LIN.
Here is a comment from Sherry. She said, it's a great presentation. Thank you very much. We'll make every effort to bring the initiative to the HHNB LIN, and the results are amazing. Samuel, on the other hand, said very informative and asking where they needed to refer the patients to Spectrum.
So we're not the only clinic within the Mississauga-Halton Lynn that provides this service. There are 4 clinics through 4 agencies that are contracted to the Mississauga-Halton Lynn to provide home care services. And each of those organizations does total contact casting. So if someone lives within the Mississauga-Halton catchment area, a referral to the Lynn for consideration for total contact casting for their diabetic foot ulcer is all that's required. The Lynn would then refer the patient to one of the 4 agencies that is doing this program, and they would be assessed, and if appropriate, then we would go ahead.
Julie is saying it's a great presentation and the success stories are really awesome. Simitri has a question about how early can they see the results, meaning how many weeks?
So the vast majority of our patients are closed by week 4 or 5 of casting. We have had a couple of patients that with smaller, shallower sites that are closed at week 2. And then keep in mind with anyone who is in a cast, once they have closed, we do cast them for 2 additional weeks to allow the tensile strength to increase. So the shortest time frame we've had someone in a TCC was 4 weeks. The longest we had was 12. Our average tends to be around 6 to 8 weeks. So it's pretty rapid. It's actually, as a nurse, it's really exciting to see how quickly these wounds close once you get the consistent offloading in place.
Yeah, it's really amazing. Here is a comment as well as a question from DL Davis. So, hello, thank you for the fine presentation. I am not a wound care nurse, but we have nurses who perform comprehensive assessments on veterans. At what point should the assessing nurses make a referral to a treating physician, and how often should the visiting nurse visit to assess response and report to the physician? And do you still recommend the use of the Braden scale?
So in regards to these patients, this is an ambulatory program through the Mississauga-Halton Lynn. We only do total contact casting in a clinic setting. It's not done in home. So the patients are referred through the Lynn to one of the Lynn wound care clinics, and that's where the casting takes place. We do use the Braden scale, but this is more for a focus of diabetic foot ulcers. So we do know that for especially ulcers on the plantar aspect, that pressure is absolutely an issue, and eliminating the pressure as well as ensuring that they're free from infection and that we're using good wound care helps to bring these sites towards closure.
Thank you for clarifying about casting that it cannot be done in a patient's home. There is a question here from.
I would just add that there are other LINs in the province that do provide total contact casting for their patients and clients. So if you do have LIN patients, it would be worthwhile inquiring with the care coordinator to see if it's something that is available in the area that you're working in. Mm-hmm.
Yeah, I believe Central East, Lynn, and HNHB are also offering total contact casting. I'm sure there are others. I'm sorry, I just don't know who they are offhand. So reaching out to your local Lynn and inquiring as to whether they have this program would be beneficial for your patients in this situation.
Thank you very much for the additional information. Here is another question from Angela. Are you able to recommend where patients can get proper footwear after the wound heals?
So in collaboration with the Mississauga-Halton Lynn, we have a clinical practice group with NSWAC nurses and wound care specialist nurses. We get together once a month. So every couple of years, we do update a resource list for vendors for offloading with lists of local chiropodists and podiatrists so that we can help hand that information out to our patients to ensure that they have the follow-up.
You might have answered this earlier, but Ann Hackett is asking whether this program is offered only in Toronto or Mississauga.
So this program for us specifically is with the Mississauga-Halton LHIN. And there are other LHINs that do have total contact cast programs. So I would suggest reaching out to your specific LHIN and asking them if they have this program in place.
The next question comes from Sherry. Is the healing process the same regardless of comorbidities?
That's a fairly broad question. It's a good one. We do try to ensure, this is specific for diabetic foot ulcers. So ensuring that people, their comorbidities are in check, that's always part of the assessment before determining if someone is appropriate for TCC. We also like to ensure that they have good blood glucose management. And that they have a good gait and just an overall wellness check too to ensure that they're appropriate for this program.
Harpreet has a question with regards to what can be done for patients who are not able to go into the clinic.
So Harpreet, that's a common issue, and with diabetic foot ulcers, hopefully most people can come to a clinic, but if they can't, referring them to chiropody so that they could have some orthotics or potential offloading done. I know a lot of chiropodists will take a pair of New Balance running shoes, and for a private fee, they can create a custom orthotic. There are, Darco is one of the many brands out there of offloading devices that can be purchased privately to provide some offloading. But I would suggest getting your patient involved with a chiropodist, because that really is their expertise, and they can help to ensure that the patient has appropriate offloading. And the other key is to encourage your patients, if they have an offloading device, to wear it every time they're on their feet, be it standing or walking, because it's the consistent offloading really that is going to help heal this.
Jenny is asking whether COVID has affected the patient's hesitancy to TCC.
We have not found that that's an issue, and because our clinic is up and running and has been all throughout COVID, we have continued to provide the total contact casting as a treatment option for our patients with DFUs. At the current moment, I have 3 patients that are in total contact casts.
Okay, so a question from Sarah. So in long-term care setting, once cast is on, who is responsible for the cast after care?
We are a LHIN-driven initiative with a LHIN wound care clinic. It's not a long-term care program, and we do not go into long-term care to put casts on. It's an ambulatory program through the Mississauga-Halton LHIN where patients come into the clinic. So it's not a long-term care program.
Thanks for clarifying that one. And the last question that I have is, have you had any challenges when it comes to compliance, and how do you successfully deal with them?
Yes, we have had a couple of issues with compliance. We had one gentleman who decided that he didn't want his cast on anymore. So we use a cast saw to remove the casts in the clinic. He used a pair of garden shears at home to remove it. So obviously there are discussions around safety, discussions around following practices. Ultimately, for that particular gentleman, we had to stop the TCC because he wasn't safe to continue with it. But generally, we find most patients are very compliant with the necessary steps with the TCC. So we haven't had many issues. And there's a healthy discussion with the patients before the onset of the TCC casting with the expectations and what to expect before we begin. And if a patient really feels that this isn't something that they can handle, then we do not move forward.
I bring it back to Grace. Thank you very much.
Thank you everyone for those excellent questions. And we do have about 9 minutes left if you have any more. There are a few more that have come in. It's in regard to the situation that you had in which a person had claustrophobia or an anxiety attack and unfortunately had to go to the ER to be able to get that removed. Has there been a situation or circumstances that have changed in which the clinic is able to accommodate situations such as that?
So thank you for that question. Just to provide some clarity around that, our clinic is open from 8 in the morning until 9 at night. So during that time frame, 7 days a week, if a patient has a concern or if that particular patient had had an issue with the claustrophobia, they could come to our clinic within those hours and we would remove the cast and assist them with wound care. This particular gentleman had his attack in the middle of the night. Our clinic is closed and we do educate our patients that if it's outside of our hours and they need help, be it, let's say their leg is swollen, they've got issues that show that they may have a new or increasing infection, or with the claustrophobia or anxiety, that they are to go to emergency. All of the emergency departments in the hospitals that are within the Mississauga, Halton, Lynn all received education about the total contact cast program prior to it being initiated. And they were all shown the cast and how to remove it. And every patient has a little card that the TCC Easy Kit comes with that shows the removal process. And they keep those cards on their person so that if they did have to go to emergency during the night, they can present that card so that the emergency department, if they were not one of the people that were trained, understand how to get the cast off.
That's an excellent contingency plan. Thank you so much for sharing that. And also in regard to the process involved, oh, there is a question here. So how do you follow up with your clients once TTC application, and how often do you access if TTC is working or not? So that was actually one along the other question I was about to ask.
So the process that's recommended with the TCC Easy TCC is that the first cast is applied and removed 48 to 72 hours after the initial application. That allows us to assess the wound, assess how the patient is coping, assess how the leg is responding to the casting system. Once we realize that everything is good, and with every patient it has been, the casting is done once a week or twice a week, depending on the size of the wound and the amount of exudate that is present. And the wounds are measured and those measurements are documented at every cast change. So we do track the progress once a week with the casting or twice a week, depending on when that cast is changed. And the frequency of the casting is directly related to the wound presentation. So if we were to see an increase in drainage, we may increase the casting to twice a week. Those that may start off with twice a week casting, as soon as we see that the wound exudate has decreased, we will decrease the frequency to once a week.
Wow, that's amazing monitoring and oversight of individuals who have the TCC on. Thank you so much. And there is, I mean, this guideline is focused on the management of existing diabetic foot ulcers. But in regard to prevention and not having recurrent visits to your clinic in regard to the management of subsequent diabetic foot ulcers, could you talk more about that?
Yeah, so keyword, offloading, offloading, offloading. So there's a lot of discussion with our patients about the need for consistent offloading to take the pressure off those areas of their feet that are dominantly taking the brunt of the pressure, especially in association with the neuropathy where they're not feeling that that part of their foot is struggling. So we do, from day one when they're admitted, start talking about the need for consistent offloading every time they're standing or walking, the need for regular and routine callus management on their feet. And we do talk about never walking around barefoot or in their sock feet, that they should always be in an offloading device, whether they're standing or walking. The importance of having orthotics or shoes or offloading devices assessed annually, or if they're appearing worn. Because as soon as you don't have that offloading device in place, you're going to get the DFU reoccurrence.
Okay, excellent. And there is a follow-up question. Sarah is asking, what offloading booties do you recommend if it's not going to be the total contact cast?
So through the Mississauga Halton Lynn, we do have access to the Darko wound healing shoe system. We are able to provide one pair of these, this system to diabetic foot patients. So before we begin TCC on their admission, everyone is placed into a pair of these offloading shoes if they are appropriate. The cost is covered by the Mississauga Halton Lynn. And then at the completion of the total contact casting process, they would go back into these Darko shoes, or if they did not get a pair of these previous to starting TCC, they get a pair at the end. And again, there's a lot of discussion about the importance of chiropody involvement, routine callus management, and being assessed by a chiropodist or a podiatrist for footwear that helps to continue the consistent offloading to prevent the ulcer recurrence.
Amazing, thank you. And there is, we'll cover a few other questions. There is someone whose hand is up. So Andrea, if you don't mind unmuting them, and perhaps we can hear from them. But in the meantime, family involvement is important as that helps with safety and assessment. If the person lives alone, is there a system in place for them?
Unfortunately, no. People that live alone, so we'd have to assess their ability to manage on their own. We have had several patients go through the TCC process that do live on their own. So there's a lot of discussion about safety, maybe using a cane initially till they get used to walking in the casting system. We talk about how to go up and down stairs, using safety rails, removing rugs, just general safety. But in terms of supports, that person is responsible for getting themselves to the clinic for the casting appointments. So unfortunately, there are no external supports in place that I'm aware of.
Okay, thank you so much. And I see that DL Davis is online. Would you like to ask your question? It looks like you're unmuted, so please feel free to ask your question if you wish. And there is also Naomi as well.
Yes, so Naomi, you can unmute yourself now. DL Davis, you are unmuted as well.
And as we wait for DL Davis and Naomi to ask their questions, just wanted to let you know that, again, this presentation is recorded and it's going to be posted on the RNAO website. So Andrea is going to give you a heads up when that's available. She'll email you, and please also feel free to fill out the evaluation form that we send you because we're always looking for topics that resonate with other champions, and it's definitely a way for you to be able to communicate with us. And Naomi's saying that she's okay. So we've asked a lot of questions and there were a lot of answers that were fielded. So just wanted to thank you on behalf of the RNAO team and the participants for your presentation on best practices when it comes to diabetic foot ulcer management and specifically the use of total contact cast. We celebrate and we congratulate you on the excellent outcomes. And please feel free to connect with the presenters. They will have their contact information available and attached to the PDF of the slide deck. And in the meantime, have a great afternoon and thank you very much everyone for coming, and please check us out next month.